and the nucleus, and to some degree the annulus. Well, first of all, we'll talk about the lumbar discs first. What would be the indications for a disc replacement? Well, I think 1 or 2 level disease, discogenic low back pain, who was otherwise a fusion candidate. They failed non-operative therapy, and they've passed whatever psychological assessments you do. Well, biologically, I think the question is, can we regenerate the disc? This would be akin to what Ponce de Leon was looking for, the fountain of youth, because if somebody could put a needle in, inject something into me, and grow all my discs again, I might be a 5 handicap golfer again. Well, Jim Kang from Pittsburgh has done this in rabbits. And they use a adenovirus vector. They code in a gene that causes these cartilage cells in the disc to form transferring growth factor B1 protein, which increases proteoglycan synthesis. There's another agent, another DNA that will grow collagen, so you can grow both type 2 collagen as well as proteoglycans, and you double and triple the synthetic rate, which has the theoretic possibility of reversing degeneration. Now, when you get to nuclear replacements, these are largely done by polymers, so-called hydrogel polymers they absorb water, and the most common one is the PND. It's an encapsulated in a polyethylene jacket, and it really does absorb water, swells up, creates swelling pressure. Unfortunately, the flow times is about 5 minutes. In other words, it takes about, if you put it in some water, it takes about 5 minutes to absorb it and squeeze it out. So it's a lot slower than the intervertebral disc. And they're basically pillows and cushions. The problem with this is they're not fixing the annulus. And so that has some implications. Charles Ray has done this with a PLIF technique, did discectomies, put them in posterior, one on each side, just kind of like we do a PLIF cage, try to get them transversely oriented. And he presented this study at NASS a year and a half ago, 29 patients, and they did use the oswestry, and they actually had good clinical results, 49 to 12, but 28% of these things dislodged. And if you put them in PLIFs and they dislodge, it seems to me you're going to have some real problems. So I'm not sure this is going to work very well until they figure out how to repair the annulus. Another type is the total disc replacement. And most of these that are current in use have metal on plastic, very similar to a total knee, except it's metal, plastic, metal. So you actually have 2 articulations instead of 1. There are some with just 1 articulation. This is the Link Charity, and it has spikes that try to hold the thing in place. And it's a high-density polyethylene that's the plastic-bearing surface. This is a summary of a multi-center study from Europe, and Dr. Chapman can tell us maybe at the end of this how this thing started, since it started over in Germany. But 92 patients, 68% good to excellent results. Not far different than what we get in fusions cases. And this is one I thought was pretty interesting, an L3-4 and an L5-S1. Seems to me pretty chancy kind of operation to do. They do function. They, on average range of motion and follow-up was 9 degrees in flexion extension. They didn't report subsidence, that is the erosion of the prosthesis into the end plates. But they did note that there's a 25% loss of disc height in 14% of patients, at least 25% in 14% of patients that occurred within the first 6 weeks. And I wasn't sure if that meant there was cold flow of the polyethylene or if it was subsidence. They didn't really mention that. There were 5 out of 90 failures that needed revision to pedicle screws. This is an example of the first one done in the United States by Scott Blumenthal, and certainly looks like it's put in nicely, and the patient has done extremely well. Now let's move on to cervical spine prosthesis. What do you use this one for? Well, this would be in place of doing a fusion for an anterior cervical discectomy. And the classic patient would be one with a radiculopathy who would have that pain diagram, who we would otherwise plan on doing an anterior fusion. So we're trying to avoid doing a fusion for anterior cervical pathology. Well, why do that? Well, first of all, we know that anterior cervical discectomy and fusion is an excellent operation, probably one of our best operations. Overall, 90%, good results, very predictable, not a lot of morbidity. Patients are generally very satisfied, but long term is the problem. There are disadvantages, as we know. The biggest one is adjacent segment degeneration. It occurs in up to 25% of patients within 20 years. Also, the fusion's non-physiologic. You have the shock absorber, now you're running with a stiff segment. To some degree, you get stiffness, but most patients tolerate that. You do have this nagging business of reoperation for things like pseudoarthrosis, plate breakage, and the patient is immobilized, which after disc replacement, you don't need to be immobilized. Dr. Bryan, who really developed the one I've been working with, has this slide, and I kind of like it. If you have a bad shock absorber, do you want to replace that by welding the chassis to the axle, or do you want to replace the shock absorber? I gave this talk last week in Detroit. In Detroit, they appreciated this slide very much. So this has led the genesis to a disc replacement, and this has gone through a very thought-out investigation, and I think you would all agree that this is, I think, a well-designed prosthesis and study. First of all, looked at the loads, the kinematics, the anatomic features to lead to the design. Multiple designs were then evaluated. They were tested, first computer models and then in benchtop testing. And then once it looked like it worked in the benchtop, it was placed in different animals, survivalship studies, and then finally into human investigations. This is the Bryan cervical disc prosthesis, has titanium shells. Inside is a lens-shaped polymer that's a polycarbonate polyurethane polymer that's a little bit compressible. It has a sheath that goes around it to try to capture any wear debris. It's lubricated and you have seal plugs to lock in the lubrication. This is a blown up view and the yellow on the lower right is what the polymer looks like. It's yellow, it's very smooth, low coefficient of friction to your finger. The titanium shells have pore coats sintered on to aid ingrowth. This is what it looked like after a properly milled cavity. Much like we do total knees, there's a very complicated jig system that mills these cavities very precisely, and this locks in under a mortise and tenon type of joint. Kinematically, this prosthesis tries to match the individual motion segment. It can flex and extend to 11 degrees plus or minus, which really means 22 degrees. And because it's circular, it also laterally bends to that much. It's really unconstrained in rotation, and it has coupled motion so that there's 2 millimeters of translation during flexion and extension. It's been tested for durability, wear tests, creep, expulsion tests, and shear tests. And I'll just review, and literally hundreds of tests have been done. I'll just summarize some of the important ones. The durability is, it was tested up to 10 million cycles in a cervical spine simulator, and basically there's 1% wear of the polymer during 10 million cycles, which is estimated to be 10 years. Creep is where we just pressurize it and see what the response is, the deformation response is over time, and under loading similar to a head, it compresses about 1 millimeter. The expulsion test was literally we just took the prosthesis and tried to yank it out as hard as we can, and we set a certain safety factor, and the test exceeded that by 2 to 3 times. And similarly, we tried to dislocate the whole, not the prosthesis, but the joint, the motion segment. And again, compared to what we thought would be a reasonable safety factor, it exceeded by 7 times. Then it was placed in animal models, and you can argue what's the best animal model. Both chimp and goats are anatomically very close, and this has been tested in both those animals. The chimp study did 10 chimps, put them in and took out the prosthesis 3 and 6 months later, and then did an interbody fusion. So we did not have to sacrifice the chimps. And the purpose of the study was, first of all, test the feasibility of the thing, and also look at the wear characteristics, look at the immunologic response in the peri-prosthetic tissue when we took it out. And we found really there's no wear that we could see. There's a minimal inflammatory response. This is a prosthesis that it's taken out, and there's a little notch on it, and because of that, it looked like the design was a little bit faulty, and so the thing was redesigned so that there won't be contact where that notch was. It wore that. Then there was a second study done in goats, and I think we've had 30-some goats now. And this one was unfortunately a survivalship, so we had to kill the animals to look at things like the lymphatic system in particular to see if there's any immunologic reaction to wear debris. And at 6 months summary of the animals, there was nothing abnormal in the spinal cord compared to controls. Local tissue, there was an occasional macrophage with particles of the plastic in it, but there's no foreign body giant cells, and it looked nothing like a loose total joint where you see this incredible inflammatory response. The lymph nodes had green dye in it, and initially the pathologists wondered what the heck is green in this prosthesis. It turns out that animals had green tattoos which were picked up in the lymph nodes on their ears. But no reaction to the prosthesis, and the liver and spleen was normal. Now, it was then tested in the human sapien europaeus study, since we can't test it in the United States. And Europeans, I guess, Jens, are very happy to volunteer into studies, and I wondered if he'll be our first subject in the United States. But 94 patients in 7 centers, single-level disease, the indications I gave before. And here's the outcome on the first 24. It's very, now we have outcome over a year for the full 96, but it's basically the same numbers. 92% good, excellent results, and very few failures, no reoperations, no hardware-related problems. It did function as a prosthesis. Average range of motion and flexion extension was 9 degrees. And all patients moved at least 2. And this is just an example of Dr. Golfin's patient, 5'6". This is what it looks like, and here it is in flexion. And you can see the spreading of the spinous processes. I'll try to back it up, and you can see how the spinous processes are closed, and now they're spread, indicating that there's pretty good motion. You also get a sense that there's a little bit of anterior translation. So complication rate there was one reoperation. Some guy in France did the wrong level. One prosthetic problem, it loosened and translated anteriorly about 2 millimeters, and it was due to the mill broke during the process, didn't have a backup, and so the cavity was really never milled right, and since that's been fixed. So disc replacement for both the lumbar and cervical spine is feasible. You have to have good fixation to the bone. The problem is going to be with biomaterials and the wear, just like what the problem is in other joint replacements. We don't know what the facets mean in the disc replacement, so obviously if you start doing this someday, you don't want to choose patients with a lot of facet disease, because we're not replacing that. And just like any other spine surgery, patient selection is really important. Thanks.
Why did they pick the 6-month time period for removal of the implant from the chimpanzees?
Yeah, the goats are actually going 12 months, but the chimps were selected on an early time frame because the vets were very nervous about having this in, and so the first group we did, they wanted them taken out so we could assess whether any reactions were going on. And the second time period was basically because that's what the FDA wanted.